today with Professor John Werry. John, I know you've got quite an extensive background, and I'm going to do my very best to introduce you and your 60 years of knowledge in psychiatry. But I understand you're an Otago graduate.
That's right.
1957.
Yep.
And you're wearing your Otago grad jumper today.
That's right.
Quite proud. And you're going off to Auckland University after this, aren't you?
Yes,
to a talk.
lecture, yeah.
And you're not going for a protest? Or
No. Although I ask questions afterwards, which are in the nature of a protest.
Yeah, all right. Excellent. Sounds like I should come along.
Anyway.
Yeah. The other part is you've studied psychiatry, child and adolescence, is that right? And then you sort of went away for a bit and came back and became the head of department.
Yeah, the first one in the new medical school in Auckland.
Yeah.
So that was 1970, however long ago that was.
Okay.
Yeah.
And here I am, a 2016 graduate.
Yeah.
Okay. And you've done quite a few publications, almost 200 publications in adolescent psychiatry, and you primarily focused around conductive disorders, ADHD, and quite a few things around that.
Yes, although I also have some about delivery of services for kids.
Yeah.
But I find it is quite difficult, much more difficult to get publication of those than it is about drug studies.
Right.
You know?
Yeah, because where's the area of interest?
But I'm very, very concerned about how to deliver mental health services to kids, particularly at the primary level. We've got quite a good secondary specialist level now. I know there are holes in it, but it actually functions pretty well with the resources we have. But the big weakness is the whole area of primary mental health. But that's not what we're here to talk about, except in one way, which is the problem of, I've worked a lot in rural areas, from Te Hapua to Bluff actually, and one of the big dilemmas there is how do you deliver top flight care to people in rural areas. Now, a good example of this comes from the last, one of the last jobs I had was with Te Karawaihoara or Horaki, and they're based in Thames, but their rohi extends all the way up the Coromandel Peninsula. And one particular problem was that if the DOA, if you know what that is, the duly authorised officer wanted to take out papers under the Mental Health Act, after they have to find a GP to take out the second papers under the application. And it was almost impossible to find anybody after hours.
Right.
And that's what a simple example of how do you deliver services to people in rural areas outside working hours. And I'm very pleased to find that in fact the Waikato DHB is trialling a telehealth after hours service for people particularly in the rural areas. And I see that as a major step in the right direction.
Okay.
I guess my fear is that when the NZMA finds out that it's going to make inroads onto private practice of medicine, that they'll do what they've always done with major changes in the service delivery, which is to oppose them because they will see their business shrinking. So it's a worthwhile development, but I expect backlash to occur. One of the adages I always used to try to teach medical students was if the medical profession is against it, it must be good for the patient. But I am really bothered by the private sector in medicine at the level of primary care. It's not so critical at the specialist level because people then have a choice between a free service and a private one. But at the primary level, patients have no choice. And therefore, I believe that we have to have a system which ensures that everybody has access to the primary level. And technology is one of the tools. It's not the only tool, but I think it's a very important tool that we need to advance equitable healthcare.
Because I can imagine you've been involved in this healthcare for a very long time. You've seen it from the beginning all the way up to now, where we're starting to implement more and more technology. And it's great that we've got this telehealth coming in from the Waikato. How do you envision it to look like in another 20 years' time? What are you hoping that, say on an ideal day, someone wants to access the primary healthcare service?
Well, I mean, I think Jonathan Coleman put it very well, and I think it's unfortunate that he wrapped it up in political claptrap, but the core of what he was saying is very important, that we cannot go on with the current health service because it will bankrupt the country. At the moment it's consuming 9% of GDP, but it's projected that if we go on at the current rate, in another 10 years it'll be consuming 20% of GDP, and we simply can't afford that. So we've got to start thinking outside the square, and to me the technological side of medicine is an important part. You see, to me one of the key problems with the health service is that we have all this wonderful knowledge, but we don't know how to deliver that knowledge safely, effectively, equitably, and in a cost-benefit way, efficiently. So I would like to think that medicine will move very much towards a patient focus. We've lost the sight of that, I think. You know, I live in Auckland, and I cannot get access to my general practitioner after 5 o'clock at night. I can't get it on weekends, and they're closed for the holidays. Now, what kind of a service is that?
So if you had the opportunity to use a telehealth access, say you had a video conference at home or something like that, would you use it?
Yes, absolutely. Well, I think I told you that in the Coromandel we tried using Skype from Thames to see if we could avoid the patients having to come all the way down to Thames, and also, or our going up there. And it was quite successful, though the pictures were rather fuzzy.
I can imagine.
So I'm hoping that we'll be able to do it. And I'm interested to see that Ruth Large, who was at Thames Hospital, is one of the speakers here about how to deliver, you know, telemedicine. So
I thought with the fast change that is happening with technology, would we be leaving behind, because we've got an ageing population, would we be leaving behind the people who aren't catching up with technology as fast as the youth are?
It's a dilemma. I mean, I'm I'm a computer freak.
Yeah, you are.
See.
I always have you know more than I do about tech.
Latest ones, but it does worry me, you know, how some people are going to be able to use. You know, when Jonathan Coleman described the way the system would work, I'm asking myself, how is it going to work for my Maori patients? You know, how is it going to work for the elderly? So I think that that's a challenge. I don't think we should be defeated by the fact that it's a challenge. I think if we keep constantly the patient in mind rather than the profession and the health service, if we keep the patient in mind and ask how can we get this, what we know to them, we'll be on the right track.
I think you're absolutely right there. And finding out those barriers and trying to address those barriers early.
So I don't think anybody should accept that this is a magic bullet. It'll only be a magic bullet if we graft the other components of how to make it acceptable for people with it at the same time. And always we've got to address the problem of inequality in our health service.
Very good. Well, thank you for joining us today,
You're
Professor
welcome.
Werry. I hope you enjoy the rest of the conference.
Well, I'll do my best.
Yes,
Thank you.
Okay, thank you.
Okay.